So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid. Hey guys, welcome to the first trip of the Pharm So Hard Phun in the Sun tour. I'm super excited. Again, Jim Pruitt, aka Pharm Dean to ED, and we're doing something new today. It's going to not be about us as a podcast, but we're here to highlight one of the best known programs in the state. Again, it goes by Orlando Health. Most other people would know about Orlando Regional Medical Center. Again, the name is going to change because of how much stuff you guys are doing, and just super excited to be here today. And just go ahead, introduce yourself and tell us what's your role, and then we can get into some of the questions about the program.
Totally. So my name is Chancey Carothers. I'm one of the critical care medicine pharmacy specialists here at ORMC. I actually came down here for my PGI2 residency program, for the general pharmacy residency program. Liked it enough, stayed on for my critical care residency here. So I was here for that, and then I had a position open up during my PGI2 year for a critical care medicine specialist position. So took it, ran with it, and I've been here ever since. So in total, about 8 years here total, and about 6 years in my current position.
Perfect. So again, that's a little bit about you. Again, so tell us a little bit more about like the hospital system. What are the things you guys are known for? Like, what's the big thing? Because every hospital has a thing that they're really good at. But what are the things that Orlando Health or RMC is like known for?
Yeah, totally. Orlando Health, ORMC specifically. So Orlando Health is a large system comprised of many different hospitals. And so specifically ORMC is the flagship hospital of Orlando Health. We are that kind of the tertiary referral center. So when we have really sick patients, really complicated patients, they all get transferred from our outside facilities to us. We are the only level 1 trauma center in Central Florida, so we do see a large trauma population. We're the only burn certified center in Central Florida, comprehensive stroke center. We have interventional cardiology, interventional stroke, interventional neurology. So we have, if you can name it, we pretty much have it at ORMC. So we have a huge facility that has all kinds of services that we offer our patients.
And you guys are like located in downtown Orlando, so you get people from all over that's going to come here. And I like to think of it as like, it's kind of like a community hospital, but not necessarily have more resources than like our traditional, what we know as a community hospital. But you guys get the gunshots, you guys get the MPCs, you guys get all those things, but you also get more of the complicated patients that can't be managed by some of the small flagship hospitals, get sent here for like these interventional procedures, things of that nature. Can you talk a little bit more about like the acute care, like the ED, the ICU, like how many pharmacists do you guys have, and like what services do you guys cover?
Yeah, that's a great question. So going first to the emergency department side, so we do have 2 emergency medicine specialists, clinical specialists, and we actually recently went to a 24/7 model. So we now have 24/7 coverage of our emergency department, which was like a huge deal. It was a huge undertaking to get to that point. We actually were going to get it done a lot earlier, but then COVID kind of derailed our plans, as it did for a lot of things. So we have our 2 specialists that work in the ED, and then we have a number of our staff pharmacists who are trained and have extensive experience in the ED. So we have clinical staff pharmacists that will do shifts in our emergency department. I don't know the exact number off the top of my head of those, but several.
Yeah.
From an ICU perspective, we have a number of different ICUs. So we have our main breakdown of ICUs are our multi-system ICU, neuro ICU, burn trauma ICU, and then our cardiac ICU. And so we have a clinical specialist in each one of those ICUs that we kind of are dedicated specifically to that service line. So we round with those teams daily. We are the ones that are kind of in charge of making and developing the order sets, the guidelines associated with that. So we work very closely with our physician counterparts in those ICUs, and we're very highly specialized in those issues, in those specific areas, which I think makes our department stronger because we're not all just generalists. We all have our kind of specialty that we're like really know really well.
Okay, perfect. So again, within that, are you guys like? Are you guys more of a closed unit, I would say? Like, are you verifying all the orders? Are you doing all the consults? Do you manage basically all the things for your patients?
Yeah, so we are a closed unit. All of our ICUs are closed. With our kind of the model of how we work, our operationally, our ICU, so we are kind of all of our specialists are kind of hybrid type positions. So we do have a responsibility for all the operational components in the mornings. So when we're rounding on our patients, we're verifying all the orders because we're, with our team as they're inputting those orders, we're making those recommendations. A lot of times they're the orders that we've told them to put in.
Yeah.
We are also managing all the kinetics, the consults, TPNs for those patients up until a point. At noon, we transition away from our operational components, and that gives us our dedicated time for meetings, committee involvement, guidelines, order set development, research, meeting with our pharmacy residents to do topic patient discussions, things like that. So it's really nice to have time where we're dedicated really to patient care, and then some protected time where we're able to do all those other responsibilities that fall outside of the direct patient care.
Absolutely. I think one of the things that many people talk about now is like that role has been added on, and a lot of places may not have that dedicated time, and that's where a lot of this communication about burnout and
for sure.
How can you be able to do all the direct patient care things and all the other things that maybe we as a pharmacy community put on ourselves, but it's just the reality of what goes on. So it's nice that you guys have that block scheduled out. What about the evening? So again, most people are gonna have that daytime. What's the schedule look like? So when you guys are not on the floor, what happens from that 12 to potentially 4 or even later? Like, what's the coverage look like for that?
Yeah, so we have an ICU satellite pharmacy that is staffed with one of our clinical staff pharmacists. We have our first shift. It's a first shift. It's typically a 12-hour shift, so they are from 7 to 7, so 7 a.m. to 7 p.m. So in the mornings, they have kind of responsibilities for some operational components outside the ICU, so they focus on those in the mornings while we're taking care of the ICUs. And then once it hits 12 o'clock, they're the ones that are kind of managing the operational aspects of the ICUs. They're the ones getting the calls from the nurses, from the physicians when we're not there. Obviously, we get calls from our nurses and physicians. The specialists do outside of those times, so we're available to help. But we have until 7 p.m. is our ICU satellite, and those clinical staff pharmacists that staff in there also have extensive experience staffing in the ICU, so they're all very well acquainted with our ICU patients as well. And then we still have some evening coverage. We have less staff in the evenings after 7 p.m., so they kind of have much more broad coverage. But then after that, it really transitions away from more ICU specific staffing and more just in with our general staffing. Yeah.
Perfect. So we mentioned a lot of the things about like the hospital itself, the patient population that you guys see, and then like maybe the ED and ICU teams and the services that you guys provide. Let's talk about the residency program.
Yeah.
Many people are going to be watching this. People listen to the podcast. A good bit of them are going to be residents. And one of the things we want to figure out, so how many residents do you guys have? What are the PGI2 programs? And what are, again, some of the highlights of the residency programs?
Totally. So since I was a PGI1 here, we have expanded significantly. So we currently have 4 PGI1, just general pharmacy practice residents at ORMC. We have 2 PGI2 critical care residents. We have 1 PGI2 emergency medicine resident, 1 PGI2 pediatrics resident at our sister hospital, Arnold Palmer, which is on the ORMC campus. And then we also have 1 PGI2 oncology resident, which is associated with our UF Cancer Center, our Orlando Health Cancer Center, that is also on the downtown campus.
Perfect. So again, you have all of those. Again, talk about like what rotations, again, more for your critical care residents.
Yeah.
Like how is the rotation schedule kind of panning out? I know you have a little bit of residency, like a coordinator role as well.
Yeah. So our PGI2 critical care residents, I think we have a fantastic slate of rotations here because we have most of the specialties. So our PGI2 critical care residents are required to take 2 months of multi-system ICU. So our just general multi-system ICU where they are going to encounter all types of patients. We have a requirement for 2 months of our surgical trauma ICU. So we really focus in on the basics of medical critical care and surgical critical care for the residents. They're also going to have a required neuro ICU rotation, a required cardiovascular surgery ICU rotation, as well as an emergency medicine rotation. So we do want them to be, very well rounded. Nutritional support is a required rotation. So we have our TPN service, which is a pharmacy run service at ORMC. So they get extensive experience working with TPNs. And then we have, various elective experiences. We are a level 1 trauma center, so we have a large trauma surgery service line, and so the PGI2s can take that as an elective. We have a large antimicrobial stewardship program, so we have infectious disease as an elective as well. And one unique thing, I think, to ORMC in our critical care program is we have the women's hospital here on campus.
Perfect.
And so we actually have an elective rotation for women's health where they can have experience working in more of a women's ICU, more pregnancy-related complications, kind of some critically ill patients that we don't typically see in our adult ICU. So that's kind of a unique thing that we offer.
Yeah, so one of the things I always noticed, again, when I was in residency, when you have patients that was OB, but they were also like in DKA, we managed them a little differently, and some of those patients will be stuck in your, MS ICU because again, they probably wouldn't be managed a particular way in the women's hospital or the ward for OBGYN. So I think it's unique that you guys can actually bring yourself over there and manage those more critically ill patients. Again, where they're at, and have the service line to take care of that.
Yeah, and we're very lucky to have a women's health clinical specialist at Winnie Palmer who is able to precept our residents and give them the experience and education that us critical care preceptors here at ORMC absolutely cannot do.
Absolutely. That's one of the things, every time I get a patient that comes to me, I'm like, what can I do immediately just to stabilize them and then get them to our OB colleagues so they can like really use their expertise to take care of them. So it's like, I'm always like, I'm happy to take care of you, but I would love to get you out of here.
I'm happier when you leave.
get you out of here.
Yeah.
Again, so as I want to close up, but I want to like, what's one thing, if people are watching this, that you want people to know about just pharmacists in general and the role that we play, in particular the pharmacists that you're privileged to work with here at ORMC?
Yeah, I think that's a great question. I think there's a lot of people that don't understand when you're in the types of positions that, like in these clinical specialist roles, we think a lot about our direct patient care, and that is a huge job satisfier that for myself and my colleagues, getting to round daily on our patients, direct patient care, getting to be there for medical emergencies and respond to those medical emergencies. That's great, but there's a whole other side to being a clinical specialist in this type of role, where you're not just affecting the patients that you're rounding on daily, but you're affecting the patients across the entire health system by doing things like guidelines and order set development, helping to develop programs that are going to be used throughout the entire health system. We have such a broader role and a broader reach when we are involved with those kind of initiatives. And those are things that I think that when you're in school, and even as a PGI1 resident, I was not exposed to at all. But getting to do that is also really satisfying when you get to see these large projects that you work on come to fruition, and you get to actually change how we manage patients. I think in the last couple of years, we've had a great example of that with COVID and our COVID response. It was actually our clinical pharmacy group here at ORMC and our sister hospitals that kind of wrote our COVID treatment guidelines. And then we presented them to the physicians, the ID physicians, for their buy-in, but it was largely us that wrote our treatment guidelines. It was us that developed the vaccine clinics that were used for both our staff as well as our community. And while those things may have eventually happened without pharmacy involvement, we were the ones that were really driving that, really leading those to success. And so we're kind of working behind the scenes, but doing some pretty major things that have huge effects.
And that's the thing that I think a lot of people don't get to see. And I work face to face with a lot of the patients in the ER, and they'll tell me, oh, my physician does all these things. And your physician has a phenomenal job, has a very tough job. But when it comes to the medication side of things, we are right alongside with, or we're making these things and it's getting buy-in from. And so I think many people don't know that the role that pharmacists played inpatient when it came to COVID. We hear about the vaccines and things and outpatient, but what about the hospital, ran vaccine clinics? Those were inpatient, critical care pharmacists making these things happen, and really taking acute care to the outpatient setting to prevent them from getting more acute scenarios. So I think those are some of the things that the community don't get to see as much. And just all the work, all the guidelines, the hours and hours of times, the hours of meetings, and the spending time with your, EMR, just creator. So if you have like an Epic or you have like a Cerner, just get it from the paper to the actual, EMR. That's another meeting there. So I think many people don't understand this, the steps that it take to get there. And with a large system like this, it's really nice to see, you guys are taking care of all of these things, from the TPNs, from the bedside things, to the teaching, to the protocol development. You guys are really, really involved. So, and that's why I created this. This is why I'm very intrigued with this whole process, because I want to see what pharmacists are doing at the bedside. But the thing that most people don't consider, the thing that probably keeps me up more at night, is the other components. Some people argue that other part is the really hard part, and the bedside stuff is, after a while, again, you've been at this for 6-8 years, it gets to the point where that's okay, you enjoy it, but it's not as challenging, so to say, as the creation of an entire protocol that probably changed 20 years or so times after.
For sure.
Any other major closing things, about this institution that you want people to get from this interview, and just overall, like if they're thinking about coming here for residency, or if they're interested in a potential job in the future, what's the one thing you want to leave for people?
Yeah, I think I would say, I'm biased. I've been here for my entire professional career, coming out of school and until now. But I think we allow our pharmacists here to practice kind of to the top of their license. We have our clinical specialist group who does a lot of bedside patient care, a lot of, like I said, these protocol project development, things like that. And our clinical staff pharmacists, I think, here are involved in clinical activities more so than a lot of other places. They're getting to do a lot that are huge job satisfiers for them as well. We've had a really strong clinical pharmacy presence here for 3+ decades at this point, so we're very well established at this institution. We're well established on our teams. Our physicians look to us. They expect us to be there. If we're not there, we get texts and calls and wonder where we're at. And so I think that really just helps strengthen our residency program, helps us to produce the best candidate for whatever it is they're choosing to go on to do, whether that's going into a clinical staffing role or training to go further specialize in a PGI2 role. I think we have great opportunities, and we're able to kind of tailor our program to best fit that resident to help them succeed in whatever their goals may be.
Perfect. Well, again, thank you guys for listening to us today. Again, I'm hoping to do a lot more of this. Thank you for allowing me to come to your facility.
Sure.
It was a pleasure. And guys, I close everything out the same way every time. You don't have to be a pharmacist. You don't have to work in the ED, but everything you do, make sure you pharm so hard. Thank you.